Bismillahirrahmanirrahim. Today I am going to discuss about patients who are presenting in OPD with severe body aches and especially old age after 50 years. It is more we are more focusing in after 50-year patient old age. As in routine, we will cover the general uh, presentation. Number two, we will discuss our differential diagnosis. Number three, we will discuss about how to investigate the patient with severe body aches. Number three, we will focus on the treatment of polymyalgia rheumatica. So first of all, I am going to discuss a very common scenario patient of polymyalgia joint cell arthritis. A 79-year-old woman presents with new onset pain in her neck and both shoulders, and she was diagnosed joint cell arthritis, and she takes 7.5 milligram prednisolone per day for joint cell arthritis. Occipital tenderness and diplopia developed 11 months before presentation. At that time, her ESR was 78 and temporal artery biopsy revealed granulomatous arthritis, and the diplopia resolved after 6 days of treatment with 60 mg of prednisolone daily. Neither headache nor visual symptom developed when the glucocorticoid were tapered. Now this is the scenario. A patient severe body aches and diplopia. Visuals. If patient has visual symptoms, then think about uh, giant cell arthritis. So this is the typical scenario. Now we proceed further. Okay, what will be the differential diagnosis of a patient presenting with severe body aches? So always think about uh, the differential diagnosis. Number one, acute infection. Think about pyrexia of unknown origin. Number two, multiple myeloma. Number three, giant cell arthritis or polymyalgia rheumatica. Number four, obviously severe pain, bone pain, uh, old age, one of the leading cause of death, that is the malignancy, and the metastatic disease can present early without unknown primary. So always think about metastatic disease. uh, now we proceed in the next step, evaluation of patient by history, clinical examination, then the investigation, biochemical imaging, and then is the next will be the our diagnostic criteria, then next will be the treatment. Always ask about the acute illness, history of fever, rule out common source of infection, ear, nose, throat, CNS infection, chest infection, sore throat, dysuria, and abdominal symptoms. Rule out all the infective causes of fever, and sometimes patient can present especially diabetic patient with urosepsis, severe body aches. Then ask about bone pain, nocturia, and weight loss, anorexia, and ask about the pain. Elaborate the pain, joint pain. All the these are the shoulder and pelvic girdle. Evaluate the with association with stiffness. And next is the ask about if there is weight loss, anorexia, constitution. All these differential have constitutional symptoms. These are the weight loss, fever, anorexia, all can have. So always rule out primary by asking about any lumps, bumps, and any other past history of any malignancy. And very important differential that is not mentioned on the slide, that is the rheumatological diseases, especially SLE and rheumatoid arthritis. Always think about these two differential diagnoses. uh, after history And examine the patient by especially giant and rheumatological diseases, and rule out the infection by auscultation the chest, heart, and examination of the general lymph node and liver, spleen, and abdomen, and proceed for investigations. As we are thinking about polymyalgia rheumatica infection, pregnancy, and multiple myeloma, so we focus on the investigation of all the uh, above mentioned diseases. First of all, do the CBC with ESR, CRP, and rule out the rheumatological disease by ANCA, ANCA profile, and anti-CCP by rule out the rheumatoid arthritis. Always order the serum protein electrophoresis for monoclonal gammopathy for multiple myeloma, and do the blood culture, rule out the fever of unknown origin, and workup of the metastatic disease by calcium alkaline phosphatase and bone scan to rule out the metastatic lesions. So these are the investigations. Always do other investigation: renal profile, liver profile, serum albumin, and coagulation profile, urine complete, and we are also thinking about our infection. No, after rule out all the rheumatological, multiple myeloma, infection, and meds, we have a patient with ESR more than 100, CRP 150, then our diagnosis will be the giant cell arthritis or polymyalgia rheumatica. So, how will you uh, label a patient with body aches, elevated ESR, and CRP with polymyalgia rheumatica? So, in next 2 to 3 minutes, we will discuss about the polymyalgia rheumatica. In what is the diagnostic criteria? The diagnostic criteria polymyalgia rheumatica, there are mandatory and additional criteria. The three are the mandatory criteria which are essential to meet the fulfill the criteria polymyalgia rheumatica. This age should be more than 50, ESR and CRP should be elevated. There is elevated should be more than 100 or more than 80, and pain in both shoulders with morning stiffness. These three are the major mandatory criteria. Next is the additional criteria. These are the 7 points. Out of these 7, 4 criteria of additional should be met to label the polymyalgia rheumatica. These are the morning stiffness if more than 45 minutes. It has 2 points. Hip or pelvic girdle pain that reduce the range of motion, 1 point. If patient has ANCA or anti-CCP negative, this 2 points. Absence of peripheral synovitis will 1 point. And ultrasonic finding of shoulder girdle, if there is suggestion of tenosynovitis of glenohumeral, hip, trochanteric or subdeltoid bursitis, bicep tenosynovitis or glenohumeral synovitis, any one of these, it is 1 point. Uh, Out of these 7, 4 if are fulfilling, then we can label as polymyalgia rheumatica. Mandatory criteria: raise ESR, body aches more than 50 years, and any of these 4 with morning stiffness or hip pain, negative RA, anti-CCP negative, no peripheral synovitis or bursitis of shoulder girdle. It is suggestive of polymyalgia rheumatica. Now, what is the treatment of polymyalgia rheumatica? Polymyalgia rheumatica treatment is the glucocorticoid. कैसे देना है? we will treat the with glucocorticoid by giving the, there are three steps: induction, maintenance, and management of flares. How will you treat induction therapy? Start with prednisolone by 15 to 20 milligram per day, and goal of the treatment is reduce the myalgias, stiffness, and constitutional symptoms. For how long we have to treat? For 1 to 2 months. Consider uh, PPI for mucosal protection and bone protection for calcium and bisphosphonate to prevent the osteoporosis, as the patient has already old age and the risk of osteoporosis is there. Next, the maintenance therapy: taper prednisolone 20%, reduce 5 milligram monthly. If patient is on 20 milligram, reduce 5 month of prednisolone after 2 month. After completion of 2 months, reduce 5 milligram at 3 month and 5 milligram at 4th month, and maintenance therapy with 10 milligram. Then after 10 milligram, reduce 2.5 milligram monthly. Monitor with CRP and ESR. The management: after tapering, if there is increase the pain and increase the symptoms, it is the flare. How will you manage the flare? After flare, reassess the diagnosis, rule out ANCA vasculitis by checking the vasculitis, and consider the temporal artery biopsy and large vessel imaging, aortogram and CT angiogram of abdomen and thorax to rule out aortitis. Increase the prednisolone 10 to 20%. Then after 1 to 2 month, reattempt tapering glucocorticoid. If there is a restarting of symptom after tapering, then think about methotrexate, that has the marginal effective of the treatment. Thank you.